Alright, today I'm going to talk about two concepts that are really important to the economics of medical innovation, and these concepts are the concepts of treatment substitution and treatment expansion. And discussing these is going to naturally touch on some other concepts related to the medicalization of society, and the reason there might be a competitive advantage to developing technologies that treat a new base of patients. So treatment substitution is going to be when you develop new technologies that replace older technologies. They're improved, they're better. Your new technology that you're developing is going to essentially make another different technology that's currently in existence obsolete. Or else maybe it'll offer a couple of different options and you can choose between those options, and maybe those options, some are good for some patients, others are good for other patients. But the key here is that the thing you're treating, the underlying illness, the symptoms, whatever it is that you're addressing in a patient, is something that has technology that already treats it. So you're substituting the old technology for your new innovative technology. That's treatment substitution. Treatment expansion, on the other hand, is going to be the development of new technologies that expand the base of population that get treated in the first place. So there's going to be a number of different ways of expanding. One way is going to be to develop treatments that treat patients that currently don't have any existing treatments. You might think of rare illnesses or illnesses where the doctor just sort of throws up their hands and says, "There's nothing I can do to treat you." And there are illnesses like that. However, that's only one category of treatment expansion. Another category of treatment expansion is when you expand the definition of who has an illness. So you're expanding who you think actually needs treatment, and this can be good or bad, so I don't want to take too much of a stance one way or another, but I want to give an example. So if osteoporosis is defined as people in the bottom 3% of bone density, if that's the way you define that illness, and it is a real illness, it's something where we know those people are at higher risk for bone fractures, they're at higher risk for dying of hip fractures and many different issues that relate to frailty as one gets old. It's a real issue. But where you set that cutoff for the illness is actually slightly arbitrary. Like if you moved it a little bit up or a little bit down, that's still a reasonable thing to do. So the question is, what if you take osteoporosis and say, well, we see that the bottom 3% of bone density is one type of illness, but actually we're going to expand the people who need treatment for low bone density to include everybody in the bottom 25% of bone density. And maybe we're not allowed to call those people osteoporosis patients, but maybe we just come up with a new term that basically means pre-osteoporosis or something that's medicalized, that's really, you're not quite in the bottom 3%, you're not quite in the osteoporosis category, but you're in a low bone density category, and that means that you'd be eligible for some kind of treatment we're developing. Now, if you do that, if you develop a treatment and decide that everybody in the bottom quarter of bone density needs the treatment, then you're basically expanding the osteoporosis population by 5 times. And if you're looking to make money as a medical innovator, that's going to be a super easy and good way of doing that. If you can just convince doctors, anyone whose bone density is below X really benefits from having this type of treatment to support their bones, you can make a lot of money. So treatment expansion can include situations where you look at some scenario where the population has a density of what's normal, what's abnormal, what's problematic, and you kind of slide the scale of the cutoff so that a greater share of the population would qualify for the treatment you're developing. So that's 2 categories of treatment expansion. And then a third category of treatment expansion is to look at something that previously was not considered to be a medical condition and deciding that could be categorized as a medical condition. Let's develop something that treats it. And if you believe that you can convince people that it's a medical condition through advertising or through detailing doctors, then that could be profitable. And a slightly ridiculous example of this is the diagnosis of inadequate eyelashes that was on TV, these commercials with Claire Danes a few years back, where you can get Latisse, I believe was the name of the medication. You can get this medication to treat inadequate eyelashes as if it were a medical illness. And this gets us to the medicalization of society. There's an incentive to take things that are just bothersome or things that people don't like about themselves, that give them low self-esteem, things in our life that we think too much about, that we obsess over, that we really should just let go because there's a variation in people's body types, there's a variation in the way people look, and accepting that might be the healthiest route as a society. But if you could medicalize that and say, that thing that you didn't think was an illness, actually it's a biological illness and we have a treatment for it, that could be a really profitable way of investing in new medical innovations that could make a lot of money down the road. So treatment expansion can be fantastic. It can be treating people who really need treatment but have no other option, but it also can be redefining what illness is to expand the reach of medicine. Now, if you want to ask, where is there a problem here? One thing you need to think about is the fact that medical innovation dollars and medical innovation resources, including the scientists and the people that you put on these problems, that's a scarce resource. Like, you could imagine, what if you took up half of the chemists and half of the other scientists in the world to put them on problems like inadequate eyelashes? What that means, based on the opportunity cost of that, is that there's going to be less medical research toward treating cancer and treating heart disease and treating Lou Gehrigton's disease. These other illnesses that have existing treatments that you would have to compete with if you were to bring any new treatment to market, those treatments might get less innovation if treatment expansion is considered easier to sell. And so sometimes there's a trade-off between the types of innovations you do because scientists are scarce resources, because we can't invest in everything and we have to make decisions about which research projects we are going to invest money in trying to solve. You need to think about, where do you want to expand treatment and where do you want to develop better treatments? And you can see that sometimes the advantages of expanding the population that you consider to have an illness might be an easier task for medical innovators who want to make money down the road than actually developing a new and better treatment for something that already has treatments out there that just aren't quite good enough. So treatment expansion and treatment substitution, these are very useful concepts if you want to think about medical innovation.